TLE, though considered as a part and parcel of synovial, but TLE may also come positive with the neural tumors, which closely mimic sometimes the synovial. So TLE1 may be taking into consideration the histology, but sometimes you may have problem with the neural tumors, which are also positive with TLE1. So this is another tumor over here. Tongue, this is the mass. See, this is a huge mass, tongue is pushed up. Solid tumor without any hemorrhage and necrosis. These are the spindle cells, monomorphic. Good amount of cytoplasm, tailing is there. No prominent nucleolus. EMA positive, cytokeratin positive, vimentin positive. This is the tumor taken out. See the cellularity. Benign looking spindle cells, highly cellular. What will you call this tumor? Yes. This is cytokeratin, vimentin, BCL2 positive EMA. TLE1, though done, but I told that is also there is overlap, and diagnosis is monophasic synovial sarcoma, and this we can do for this gene fusion SYTSX1 and SYTSX2. But though it looks like a benign, but it's a high-grade malignant spindle cell tumor, it often gives rise to metastasis. This is another tumor, the soft palate. What is this tumor? Spindle cells, fat cells, and acellular collagenous material. These are the connective tissue. These are not the blood vessels. This is the tumor cut surface. This is the tumor, acellular collagenous, spindle cells, fat cells, mature fat cells. No lipoblast, no arborization of the capillaries. See, this is very classical of acellular collagen, spindle cells, and fat cells. Any diagnosis? CD34 positive in the spindle cell, 100 CD100 positive in the fat cells. Diagnosis intraoral spindle cell lipoma. This I have already shown. I do not want to hide. No lipoblast or arborization of the capillaries, thin uniform spindle cells, mature adipocytes, and ropey collagen. Take precaution. These I had a lot of problem. When I was doing FNAC from the beginning, I was not using gloves. I used to do this FNAC by putting the finger in the tongue depression, like tongue depression, doing FNAC with bare hand. But this taught me that you wear gloves, take precaution, and see what is the tumor. Red, highly vascular lesion. This is uvula. This is the mass. This is the mass. Bone destruction is there. Spindle cells with huge hemorrhagic background. Angry looking tumor. I was scared for at least 1 month after doing FNAC. I'm giving you the clue. Totally scared after when the diagnosis was given. From then onwards, I'm wearing gloves. See, these are the spindle cells. Highly cellular, but there is lots of blood in the background. Any diagnosis now? Intact mucosa, plenty of blood vessels, inspissated RBC. Spindle cells, endothelial spindle cells, inspissated RBC. What is the diagnosis? Correct. So this is the inspissated with spindle cells. In between there are inspissated RBC. Not only that, inside the cells there is intranuclear RBC also present. Very classical of Kaposi. I have not seen any other case after that. Kaposi occurring in the mouth. Kaposi may occur in the skin, but in the mouth, that to Kaposi I have not seen. And this is PSD positive. What are these? These are ingested erythrocytes with a PS with diastase resistant. And this is CD31 positive, but the marker is human herpes virus 8 latency nuclear antigen 1, which gives very good granularity in the nucleus. These are not my slides, these are prepared from outside. The material was sent and they did the beautiful stain of human herpes virus 8 latency nuclear antigen positive. And this is intraoral Kaposi sarcoma caused by Kaposi sarcoma herpes virus, human herpes virus, lymphatic endothelial cell origin, and this is an oncoprotein which causes proliferation of the cells and give rise to the proliferation and then turns into malignancy. The HIV infection augments HHV8 replication. Pleomorphic cell tumor is this is the patient with these round cells, and this is the tongue depressor is used, and these are the cells, highly pleomorphic cells. Round cells, pleomorphic cells, giant cells, all are there. See the amount of yield. If you do not give so much satisfaction, how much cells we can get, almost like more than histopathology, but architecture is maintained. So beautiful with MGG stain. So beautiful, you can see from the oral cavity. And these are the cells. Tumor excised. What are these? Cartwheel pattern. That already was highlighted, cartwheel pattern of growth, and this is highly malignant. We can see that the tumor giant cells, mitotic figures are there, but very classical cartwheel pattern of growth. And this is the diagnosis of CK negative, Vimentin positive cartwheel pattern, Desmin negative, CD34 positive, HMA45, CD34 in the blood vessels, CD68 SMA focal positive, S100 positive, proliferating at 40%. Diagnosis malignant fibrous histiocytoma of oral cavity. Now this is another tumor over here. Prominent blood vessels. Clinically, very important, we can find tumor intact mucosa growing with prominent blood vessels. So this is the tumor. Highly pleomorphic cells, adipocytes, see the mature fat is there. And these are the arborization of the capillaries we can make out. So much things come out in the FNAC. We should look at each and every corner, see the beautiful arborization of the capillaries are there, along with the lipoblast, mitotic figures. So this is wild red O is positive. Its diagnosis is prominent nucleolus, highly pleomorphic tumor. The cut surface, we can see these are the prominent blood vessels, solid fleshy areas over the tumor. And this is the tumor with this lipoblast, mitotic figures. These are the cells which are epithelioid or some spindly. But this is a very eccentric type of nucleus in a classical lipoblast. So this is diagnosis, pleomorphic liposarcoma, S100 positive, MDM2 negative. Where MDM2 come positive? In which tumor of fat tumor MDM2 come positive? This is negative, where it comes positive, well differentiated and de-differentiated. So that distinguishes that it is a pleomorphic liposarcoma. So another tumor coming from this area. Rounds, and these are the pleomorphic, highly pleomorphic cells, rhabdoid cells. These are rhabdoid cells, eccentric nucleus, mitotic figures. And these are this is the pleasure of a cytologist. A cytologist is God-gifted, I think. The patient can see, radiology can see, cytology can see, cell block, IHC, follow-up, patient, specimen, what not. Histopathology only you see the tumor but not follow-up. You do not see the patient. You see only the tumor. But cytology sees all, from the patient till IHC. Cell block you can make, specimen you can take. So this is the very interesting part of a pathologist, to go through each and every nook and corner of a patient. That is why my first choice, both in PGI Chandigarh and there, first choice was in pathology. Even from third year, I liked pathology. I left medicine because medicine is a part of pathology. Oncology is a part of pathology when you see the patient. That is the most interesting part. A person taking pathology as first choice in such a great institution like PGI, where I entered also in medicine, but I took pathology. Because this is my interesting, I grow in from third year. When I became the house staff in medicine, went through the wards and see the patient, what is happening. And more interested was in oncology, going to the radiotherapy department. What is this tumor happening? What is that? From the third year, when I was hardly 20, touching those ages, I liked the tumors. So this is the cell block. You can see the tadpole-shaped cells, very classical of rhabdomyosarcoma. Yes, the tumor excised, classical pleomorphic rhabdomyosarcoma. No need to do staining, desmin positive, myoglobin positive, vimentin positive, diagnosis pleomorphic rhabdomyos. This tumor creates problem. Who can give a diagnosis? I will give a big hand. What is the diagnosis in this tumor? Ulcerated lesion, I am telling. Giving a clue, ulcerated lesion over maxilla, right? So this is the tumor with bone destruction. Two types. Is it a synovial sarcoma? Biphasic, glandular, and spindle cells. First, we will think, as we are dealing with soft tissue tumor, first your impression will be biphasic synovial sarcoma, because epithelial element are there, spindle cell element are there. But when you go through this, is a glandular, highly malignant glands. Mitotic figures are there. See the glands. Tremendous proliferation. And if you see the spindle cells, see the spindle cells are highly pleomorphic. They are also highly malignant. So both epithelial is malignant, the spindle cell is malignant, glandular cell is malignant, highly malignant. So is it a synovial sarcoma, high grade? Do we get such type of proliferation in high grade synovial sarcoma? No. We do not get this type of pleomorphism, we do not get this type of mitotic figures, then rule out synovial sarcoma. Synovial sarcoma may be high grade, but they do not show this type of molecular cellular features. So what is the tumor? See the epithelial and spindle cells. Bone destruction. EMA positive, vimentin positive. Diagnosis? Sarcomatoid carcinoma or carcinosarcoma. So one should be very cautious. If both elements are present, see the elements, whether they are, how much malignancy are there. It is a carcinosarcoma or sarcomatoid carcinoma, and basically it is a epithelial tumor showing mesenchymal differentiation, which may show rhabdomyoblastic differentiation, fatty differentiation, osteosarcomatous areas in this sarcomatoid carcinoma or carcinosarcoma. Molecular classification is the last part of my lecture, and we have already shown the round cell. Now we will show one tumor which is very important for the postgraduate students. I felt GIST. GIST is coming up. If we do not know GIST, we should not sit for MD examination. GIST is very, very important. If we do not know GIST, we should not sit, because GIST is totally changed now. GIST has totally changed. So this is SDHB deficiency. GIST, 90% are KIT or PDGRF alpha mutated, but some are SDHB deficient. What stain we do? We do SIKIT, DOG1, and CD34. CD34 positive is esophageal, small intestinal, and rectal tumor, CD34. Rest are KIT and DOG1 positive. So this is an extra-intestinal mass. This is urinary bladder. This is the tumor. And we did an FNAC. What are these cells? Epithelioid cells. Highly cellular. Eccentric nucleus, good amount of cytoplasm. See, basically epithelioid cell tumor, but doesn't show so much malignancy over there. Looks like as if it is a benign looking cells, but classical epithelioid cells. And this is the microbiopsy I showed in the morning, that if you find a chunk of tissue, process it, and this will give the very beautiful microbiopsy was there from the aspirated material, and this is CD117 positive. So we should keep in your mind, any epithelioid cell tumor, intra-abdominal, think always whether we are dealing with GIST. Apart from extra-intestinal GIST, extra-intestinal extra gastrointestinal stromal tumor. One is GIST, gastrointestinal stromal, one is GIST, extra gastrointestinal stromal tumor. It occurs as retroperitoneal or omental soft tissue, and they give typical epithelioid and spindle cell morphology. And this is CD1 positive, DOG1 positive diagnosis, epithelioid E-GIST. Gastrointestinal, most common mesenchymal tumor. It occurs in stomach, small intestine, rectum, and esophagus. E-GIST grow within the abdominal cavity, not connected with the intestine or stomach. It grows in the omentum, mesentery, and retroperitoneum. Now, about 80% GIST are mutated. GIST grows by mutations of c-KIT or platelet-derived growth factor receptor alpha, PDGRF alpha or c-KIT, CD1 also. So 80% GIST are KIT